Good evening, everyone. And today I'm taking you through my journey of endophthalmitis. Even though it's a short journey, I hope it is interesting. So the talk revolves around these topics, introduction. So this part, I think it is mainly a focus for PGs and specific case examples, complications, conclusion and acknowledgement. So endophthalmitis is inflammation of the inner layers of the eye with exudates in the vitreous cavity resulting from intraocular colonization by microorganisms. Anybody, quick question, PG. So what is panophthalmitis? All the layers are involved. Okay. So we call it acute when the onset is less than 6 weeks, chronic more than 6 weeks, and early infection. So acute and chronicity differs from early versus late infection. In early infection, we mean to say it's still a milder form of infection where we might see hypopyon or no, but the fundal glow is still slightly visible. Some retinal details we might be seeing. Whereas in advanced disease, we describe the typical yellow glow or no glow. None of the retinal details are seen, only PL vision, and ultrasound shows plenty of vit exudates. So etiology-wise, it can be bacterial or fungal, and symptoms. So this is what I want you to pay attention. Patient typically comes with eye pain, drop in vision and red eye. But none of these are like, patient must not always present with eye pain. Sometimes it can be a quiet eye also. But we look for these specific symptoms. And signs, hypopyon and lid edema are shown in various studies to be very commonly noted in these patients. So when you're in emergency or in your clinic, when patients present with all these features, endophthalmitis should be kept in your mind. Any acute red eye, endophthalmitis should always be at the back of the mind. And others, like specific to each scenario, it can be a bleb-related infection, or it can be a wound-related things in case of trauma. It can be an intraocular foreign body, or in cases of endogenous infection, it can be associated systemic infection. Patient might walk in a stretcher with some renal abscess, pneumonia, so many things. So we see patient as a whole. So the most common differential is TAS. Quick question, what is TAS? PGs. Okay, so this is inflammation of the eye caused by non-infectious substance. Typically, some contaminated irrigating solutions, they usually present within 24 hours, whereas post-operative endophthalmitis, usually we see more than 2 to 3 days. However, very virulent organisms can present early, and they typically respond very well with topical steroids, sometimes systemic steroids. The response to steroids is very dramatic, which we may not see in endophthalmitis. So the other common scenario, especially for a chronic endophthalmitis, is patient comes with some heaviness, redness, some photophobia 2 to 3 days after stopping pred food. I'm sure everyone who has done emergency posting must have come across one patient of SN with a rebound inflammation. So we should be knowing, we should know to differentiate between rebound inflammation and chronic smoldering postoperative endophthalmitis. And some pre-existing uveitis, which patient can go for surgery, they might throw excessive inflammation. So we should be able to distinguish all these entity from endophthalmitis. When in doubt, it is always better to err on the side of endophthalmitis. So clinical classification is most common type is exogenous, with post-surgery accounting for 75%. They are more common. They are generally associated with good prognosis, especially with less virulent organisms, followed by post-trauma and endogenous. So investigation. The most important investigation is ultrasound. So we look for vitreous dot echoes, membrane echoes, retinal detachment, choroidal detachment. In post-trauma cases, we look for scleral dehiscence, intraocular foreign body. Sometime when we are following up with the patient, we do serial ultrasounds to look for worsening. Because in many situations of endophthalmitis, be it pre-treatment, post-treatment or during treatment, the media remains hazy. So ultrasound is an indispensable tool for looking for resolution or the course of the disease. The monitoring with ultrasound is very important. So there we look for T sign whenever we feel clinically the patient is worsening. Also, sometimes CT orbit when we are not sure of the foreign body, when the dehiscence is doubtful. But anyway, in endophthalmitis, we directly go in, we don't wait for CT, but still it could be helpful in certain situations. Also, when the patient presents with severe proptosis, periorbital edema, it will be important to rule out and a component of orbital cellulitis as well. So systemic infection, they come in endogenous endophthalmitis. So here we look for two things. One is the cause, other is the effect. The cause is the source of infection. It could be a dental abscess, it could be a urinary tract infection. So there we do urine culture, blood culture and all this. And effect, just like the eye, the bacteria could have caused infection in other places. Most importantly, we check for echocardiogram for vegetations and chest x-ray, ultrasound abdomen. Ultrasound abdomen, again, most commonly in previous days, liver abscess used to be a very common source of infection. So these things we'll have to remember. And miscellaneous or UBM and antersegment OCT, and especially in these cases, it's very important to document, because endophthalmitis, many times it turns out to be a medico-legal thing, especially post-traumatic and post-operative endophthalmitis. So any case, we do a proper documentation, more so in cases like these. UBM and ASSVT, UBM mainly used for chronic fungal endophthalmitis, where we want to see any granuloma around the pars plana ciliary region or around the IOL. And ASOCT sometimes look for scleral lesions or some of the corneal lesions. So every investigation has specific indications. The most important investigation being ultrasound.
Janani, just one point. On ultrasound, you also need to look for dropped lens matter. Because very often if you have retained lens matter or nuclear fragment, they can throw up a very severe inflammation. So in ultrasound, you need to look for that as well.
Yes. So microbiology, gold standard is of course culture. So out of this, so many things in this slide, the most important thing what I want you all to remember is these organisms, Klebsiella, Pseudomonas, Group B Streptococcus, also known as Streptococcus agalactiae, and Aspergillus. They are associated with very poor prognosis. Klebsiella and Pseudomonas being multi-drug resistant, they are inherently generally resistant to the empirical antibiotic which we use, which is vancomycin and ceftazidime. So when culture is isolating these organisms, we should be on our toes and we should look for sensitivity. We should follow up the patient more closely than we do for other organisms. Of course, we take the sample. In case of mild infection, we go for an AC tap. In severe infection, we go for vitrectomy. But any tissue from the eye can be sampled, like intraocular lens, corneal button, sometime vitreous, that cassette bag also we can use. We should remember that the direct isolation is possible from liquid media like aqueous, liquid sample like aqueous or vitreous, and IOL, corneal button, mostly from here we do culture and see. So when we ask for the preliminary report, we should know this thing. And for fungus, direct isolation is very important because culture takes long time to grow. And in P. acnes also, it is important to wait till 2 weeks for the organism to grow. And PCR, so PCR is only an ancillary test. It should, our management should not entirely depend on PCR, because in bacteria, false positive is very common for PCR because of the contaminant, and false negativity is very common in fungal infections because it is difficult to degrade the fungal wall and it is very difficult to detect the fungal DNA. And when coming to sensitivity, of course, this is the main part which helps in achieving infection control with fewer injections, fewer number of injections. Hence, it is very important to look at the sensitivity value even if the patient is clinically doing better with the empirical antibiotic. Sometimes, especially in fungal infections, the in vitro may not translate to in vivo. So all these investigations, it's only ancillary. Our preliminary or priority should be on clinical assessment. And the most common organisms in acute postoperative endophthalmitis is coagulase negative staphylococcus, most commonly MRSA or most commonly Staphylococcus epidermidis. And next comes gram positive like Staphylococcus aureus and streptococci, then gram negative bacilli. In Asia and India, gram negative bacilli is also quite common. In chronic postoperative endophthalmitis, P. acnes, Propionibacterium acnes tops the list, followed by again coagulase negative staphylococci, followed by fungal infection. Trauma, again very variable, but gram positive, gram negative, and bacillus. Bacillus is one of the most important bacteria. It just eats the eye within 10 to 12 hours. So whenever there is a foreign body and very bad injury, very poor presentation, we should, especially injury with vegetable matter, we should remember bacillus could be a cause. And we have to be very aggressive. And endogenous fungi is the most common cause, and Candida is more common among the filamentous and the yeast. And like I mentioned, Klebsiella is known to be inherently resistant to multiple drugs. So these things we will remember, bird's eye view for microbiology. So intravitreal injections, they are the mainstay. because it can be given preoperatively, during surgery, and postoperatively. It is important to prime the patient that even after surgery, the patient will have to receive multiple injections. More than the surgery, patient finds injection being very painful and very agonizing. So there is a lot of counseling, and we have to prime the patient from the beginning that this is a process, this is not a one-step thing. And most of the drugs, the quantity injected is 0.1 ml, the concentration varies. And initially we start with broad spectrum, vancomycin for gram positive and ceftazidime for gram negative. And we have to remember that after the cultural sensitivity is obtained, we'll have to switch based on the sensitivity. And vancomycin tends to precipitate, so better not to be combined with other injection. However, few studies have shown that even if it is combined with the ceftazidime, even they precipitate, the action is not getting affected. And we have to remember that less half-life is there in vitrectomized eyes. Like drugs like vancomycin and amikacin, they are heavier drugs and they are excreted through the anterior route. And drugs like beta-lactamase, they are lighter drugs and they are excreted through the posterior route. Injecting dexamethasone stabilizes the RPE pump, and hence it can increase the half-life of the drugs which is excreted via the posterior, which are cleared via the posterior route. And one more thing, fluoroquinolones is cleared both by the anterior and posterior route because of Zwitter ions. Hence, the half-life of fluoroquinolone is so short. That's why we keep injecting ciprofloxacin every day. And of course, it is important to have a correct dilution. We have an endophthalmitis table from SN in-house publication. Even though we know it is always better to check once before doing the dilution. And we combine with DEXA when we have ruled out fungal infection. So it is in a phakic or pseudophakic eye, we give through scleral route, which is a bit painful. In a phakic eye, we prefer intracameral route. It is roughly repeated in 24 to 48 hours, depending on the patient's response, depending upon the virulence, and so forth. So retinal toxicity, so whenever we are injecting some drug like amikacin, which is known to cause macular infarction, it is better not to repeat too frequently. Second, after injecting, the patient can be made to sit so that the drug doesn't get exposed to macula. These smaller things we have to remember. And in children, these injections need to be done under GA, but little older children, we can patch the other eye and we can still, try giving, especially intracameral, we can still try. And the major limitation of managing, major challenge in managing fungal endophthalmitis is limited availability of antifungal drugs. And there are many new drugs in the horizon like intravitreal piptaz, colistin, linezolid, daptomycin, caspofungin, and micafungin. So these drugs, intravitreal injection. And surface infections like keratitis, blebitis, or scleral tunnel abscess, here we have to be very judicious in using topical steroids. Sometimes initial 2-3 days we have to give intense antibiotic, especially fortified antibiotic, and then we start the topical steroids. Otherwise, in endophthalmitis, we tend to give hourly topical steroids. So then systemic main role is in endogenous infection, and it's also a good idea to remember these drugs which have very good intraocular penetration, which are been given intravenous. They are vancomycin, ceftazidime, cefazolin, and fluoroquinolones. Hence, we usually start ciprofloxacin 750 mg BD for most of our even postoperative infections. We give a systemic coverage as well. So surgery, less is...
Yeah, one more problem with anti-VEGF is most of them are fungistatic, not fungicidal, and that's another reason why you need a prolonged treatment. Penetration is the issue of the things.
Yes.
Yeah.
So the aim of surgery is debulk the vitreous so that the microbial load is reduced and the antibiotic, they are able to work on the microbes. And the most important challenge, Devika. So what do you do when you don't see the infusion? No, absolutely no glow. No view. It's a post-operative endophthalmitis, pseudophakia.
We can use AC maintainer in such cases.
Okay.
Or we can go inside with a bent needle, 24 gauge needle. We can see the tip inside if possible, clear the exudates behind the IOL, and then place the infusion cannula. Or if the bag is also studded, we can remove the IOL and then proceed by keeping it in AC.
So the patient pays some 60,000-70,000 for the IOL. So unless, I don't say we have to retain, but chronic endophthalmitis, the threshold should be low. But in acute postoperative, we tend to, preserve. At least we take that call in the second sitting. Yes, one option is to use a bent needle infusion. Second option, like she told, we can use an AC maintainer. And third option, if CD or RD is ruled out, you can use a 6 millimeter cannula. Okay. And sample taking. So when you want to take the sample, or what will be the ideal procedure?
Ma'am, first, without switching on the infusion, we first take the undiluted sample, and then we switch on the infusion. And then
we prefer taking undiluted sample. And is there any, if you feel the eye is hypotonous, is there any option? Sometimes, very rarely, we can even put air and we can take. And the other option is to at least fill the anterior chamber with visco so that the globe is a little bit formed, and then we take from the vitreous.
Just, I have one question for Dr. Anand. We have a centrifuge because this is a practical difficulty. Most of these eyes are hypotenuse. We try our best to take undiluted sample, but sometimes they just collapse. So if we get, and if allowed to keep the infusion open, probably we will be able to get a large quantity of sample as well. So if we centrifuge that, because we know that infusion is sterile, it's not like contamination. So doing centrifuge, will we get an equal amount, quantum, or will it not dilute our outcome or result?
So you have access to a centrifuge in the OT, or like you said?
No, we will have to collect in a syringe and pass it on to you, not in the OT.
No. So centrifuging will basically suspend all the pus cells and the bacteria. So even if you give diluted vitreous, even if it is going to be a 50 ml or up to 200 ml, we just distribute in 50 ml tubes and centrifuge the whole thing. And all the deposits, we pool it and then use it as a sample for culture. No, if sometimes we get cassette bags.
No. I'm talking about vitrectomy. During vitrectomy, undiluted sample. So if we can manage that way, so probably we will still be able to, continue infusion on, because sometimes I was hypotenuse and we are worried about it. Quite sometime it happened that sudden globe collapse and then other dislocations started, anterior chamber hemorrhages and all those things. We landed in a few cases. We try our best, but once in a while it still happen. But if it's acceptable that, so the standard practice is undiluted, we keep on talking. There was a time we did not have centrifuge, but if we have centrifuge now, is it okay if we give a diluted sample to you?
Yeah.
Which
like
will able to
if cellular material is not there, we'll report, so sample may not be good enough. But if you get enough pus cells, then they're likely to be organisms also.
I think that will come, because cutter will always be in a pus cell and turbid vitreous. But infusion is on, so eventually, obviously, it will be relatively diluted.
Yeah, it should be fine, sir.
Yes. And many a times after block only, because the side ports will be leaking, it remains soft. So one has to look for all these side ports, main wound, whether they are leaky. It's better to at least put some visco before even making the sclerotomies actually. Suture also, yes sir, correct.
So you can take as much undiluted sample as you want because he has a centrifuge.
Yes.
The point is that it doesn't, and you have to visualize what you're cutting.
Yes.
Blind cutting will not give you good sample.
Yes. So, and after we have taken the sample, and the most important problem in all these cases, especially in postoperative endophthalmitis, there will be severe anterior segment inflammation. So sometimes we'll have to clear the hypopion. We have to do a good AC wash. Sometimes there is a membrane which is plastered over the iris IOL. Very carefully we have to remove this. Sometimes we make a nick with the capsulotome, that needle, and we tend to remove the forceps. But again, when you're removing from the IOL, we have to be a little bit careful. And in cases of associated keratitis, we may have to do with a K-Pro, or if the cornea, what they are going to take is a very large graft, then we'll have to do under open sky. So we have to be prepared for all these options. And when it comes to lens management, if in endophthalmitis, when the lens is clear, we can still try to spare. Or if there is so much exudates around the lens, then we go for lensectomy. Like I mentioned, IOL in acute setting, we still tend to preserve it. But in chronic case where we know everything is happening around the IOL, in selected organisms like fungus, nocardia, we tend to remove the IOL. And capsulectomy, especially in cases of P. acnes. we tried to do core vitrectomy, but however, there is a recent study, complete and early vitrectomy, where they suggest more than core vitrectomy, PVD induction. But again, it is better to be little conservative because media is hazy. And media might be hazy, we may not add to the iatrogenic complications. And PVD induction, the retina will be edematous, most of the retinal vessels is sclerosed. I think it's better to do core vitrectomy as minimum as possible and close the case.
Yeah, actually, we don't mean core vitrectomy. Do as much debulking as possible. We word as
yes,
core
sir.
vitrectomy, that does not mean we stay only anterior mid-vitreous cavity. Do as much debulking as possible, and to the extent when you start seeing blood vessels or some retina view is there, and then stop at that. Don't want to go aggressively, like yes, rightly you mentioned, don't want to induce PVD, don't want to do base excision. That eventually going to create problem. Don't want to go suck the exudate sitting on the retina.
Yes, sir.
But do as much debulking as possible so that you have a view of retina and then come out. But I won't say use just core vitrectomy is the word. That what to mean is anterior mid-vitrectomy. We don't go beyond mid-vitreous. We don't do that. We definitely go much more than.
More than that, yes. So in cases of associated IOFB associated ENDOF is a mandatory indication to remove the IOFB even if it is inert. And associated detachment, again, two school of thoughts. If the view is clear, if it is possible to proceed, we can proceed, do the whatever detachment, whatever needed, LPFC, oil exchange or laser, so whatever possible. If the media is very hazy, if the surgeon feels that we might land up in more iatrogenic problem, it can be reserved for second sitting also. And of course, watertight closure, all the previous wounds, sclerotomies, everything prefer to suture, and intraocular antibiotic depending upon the scenario. Sometimes when we take the sample, sir calls within 20 minutes or 15 minutes, they call and tell this could be the likely organism, especially fungal. And major intraoperative complications that we fear is hemorrhage and retinal breaks, especially hemorrhage from the iris. When we are trying to remove the membrane, it can sometimes be really problematic. So when we are removing that antisegment membrane, it's better to be little careful. Once the pupillary area is clear, I think probably we can stop there. And course of the disease. So this is the most important thing. So it is not over with the surgery. So post-operatively, we have to follow up the patient. We have to give injections. The most important prognostic factors being initiation of treatment from onset of symptoms and secondly, baseline visual acuity and the virulence of the organism. So signs of resolution, as we all know, the pain reduces, visual acuity improves, chemo, swelling, everything reduced. Then hypopion gets reduces. If it is no hypopion, only fibrin, it retracts. And media clarity improves, retinal vessels you are able to see. And after a point, we stop the injection, say after 3-4 injections, we stop and see if there is any worsening. When the most important signs of worsening, increased pain, chemosis, periorbital edema, UOM restriction, and loss of vision, these all mean that it's going towards panophthalmitis. And sometimes it happens so that the entire AC is filled with exudates, corneal decompensation starts. So all this we have to watch for. And in ultrasound, there can be retinal detachment or T sign. These are also signs of worsening. So now the actual class starts. So this is a diagnostic dilemma. So 2 cases I have put for diagnostic dilemma. So this is a 33-year-old male who cannot speak or hear with a subnormal subnormal intellect. He is diagnosed as a case of query uveitis elsewhere and congenital glaucoma, who has underwent TRAB long back, some 15-20 years back, and his BCVA was 618, which was documented 6 months back. So he will be able to tell if there is a vision drop, but he may not be very clearly able to say exactly when it happened and so on. The right eye has been the poor eye and left eye was the better eye. That's why probably patient came to us. And I don't have an anterior segment picture, but the AC had a severe inflammatory reaction, no hypopion. And in the fundus, we could see yellow exudates. And the other eye also had iris nodules kind of picture. I have pictures I'll show. So it was a very difficult to diagnose whether this is an uveitis, but then why it was all quiet for so many years, suddenly why it has to come, or if it's an endophthalmitis. Because it's a subnormal intellect, there was a question of query, trivial trauma, traumatic endophthalmitis also. And after second opinion, I have taken for vitrectomy and no growth. PCR was also negative. Still, we gave 3 doses of VCD. And after careful discretion, we followed up the patient. We started oral steroids also because right eye had vitritis. So we need to start management for the right eye also. So this is the POD2 picture. Because the patient came late evening, I couldn't take the first image. So we can still, in POD5, we can clearly see these, yellowish vitreous exudates. And the entire vitreous cavity was filled with these kind of exudates, but not much sclerosed vessel I could make out on table. But if you see the 6 weeks picture, it does show some sclerosed vessels, which we commonly see in cases of infective etiology. And we can see this POD2, it is not bleb related thing. There was no blebitis or anything. And other eye, like I mentioned, there are iris nodules and mild vitritis. So at 6 weeks, patient vision improved to 618 in the left eye, and right eye also improved to 660, eye quiet. But the IOP went very high, so he needed a diode CPC procedure. So here we erred on the side of endophthalmitis. Still we don't know whether this is infection because the culture was negative, PCR was negative. But patient did well. So sometimes this situation can be there. And on table there was no wound or anything. So the second case, this is somewhere elsewhere diagnosed as a case of uveitis but not treated. He came with a complicated cataract. The anterior segment picture was suggestive of some uveitic, say something like Fuchs. And sorry, again I don't have an anterior segment picture pre-op. So this was the ultrasound, hardly any echoes. And he underwent phaco-IOL anterior vitrectomy. Intraoperative PCR was noted. But IOL was placed in sulcus. So POD1, there was a fibrin over IOL. So fibrin is an important sign, but however this patient is under oral steroids, it's an uveitic eye, so we may not be alarmed. But in POD4, this patient clearly told with the complicated cataract he had some 3/60 vision. Now not even that vision he has. He feels that the vision has significantly dropped. And there was excessive fibrin, no glow, but again no hypopyon also. Patient is on oral steroids. And we can see these vitreous exudates. Again, very difficult to differentiate whether these are kind of, post-operative inflammation or no. But then we went ahead with vitrectomy. And so it grew this Staphylococcus epidermidis. And we gave 4 doses of VCD. The patient, first week, he improved to 636. And then so initially when the culture came positive, we had stopped oral steroids. But then we resumed back because it was bacterially, anyway steroids is going to help. And then at 6 weeks, he improved to 6.9. So the thing is that in severe inflammation, even in an exaggerated inflammation, some fundus details we should be able to see in most of the cases. However, it's not the hard and fast rule. But some red glow, some retinal details we'll be able to see. Unlike in an endophthalmitis, which is full blown, we may not be able to see any fundus details. The entire vitreous is filled with X-rays. Again, hypopyon, of course, it is tending more towards endophthalmitis, but this patient, he was already on oral steroids, probably that had masked the hypopyon. And as we can see, there are some old chorioretinal atrophic patches, not sure what was the cause. So based on this, he was told elsewhere to have uveitis. So this is a flowchart which I have made. Basically, any acute form of endophthalmitis, be it post-operative, bleb-related, endogenous. So when it is an early infection, like I mentioned, some glow is seen, retinal details seen, then we go for tap and inject. EVS study nowadays, it's not followed many times, and it came only for post-operative endophthalmitis. And when patient presents with, say, late infection, there is absolutely no glow, very poor vision, ultrasound is filled with exudates, we directly go for vitrectomy. And when we go for tap and inject, if it is worsening, again we switch to vitrectomy. After vitrectomy, we take sample, we follow up with post-operative, antibiotics, DEXA plus minus depending upon the etiology. And then we follow up the patient. Finally, after a point, we stop the injection and see if he's worsening. Then we discharge from our care. We call after a month or so. But if the patient is worsening, post-vitrectomy also, so we do try giving injection. Sometimes some people tap again at this stage and see if you are missing out something. In worst cases, we go for vit lavage again and antibiotics based on this sensitivity as well. So like I mentioned, these are the common organisms. When an associated NLD obstruction was missed, pneumococcus, very notorious organism. So these organisms I have put for every infection in the side. But it doesn't always follow this rule, but they are the most common organisms encountered. So coagulase negative staphylococcus have a little better prognosis. They usually present later, little more than 4 to 5 days. But if we see fulminant acute postoperative endophthalmitis less than 2 days, especially in a diabetic patient, we have to remember gram negative, especially Pseudomonas and staphylococcus and streptococcal, other than epidermidis. So we have to look for the side ports, and all the wounds need to be sutured, like sir mentioned. We wash the anteroresmal. Most of these steps I mentioned in the surgical slide, but usually they do well with the 3 or 4 injections. And if GNB, we tend to start oral steroid because these endotoxins, they incite a much more inflammatory response. So we start oral steroids systemically also. And very poor prognosis is onset less than 2 days, corneal infiltrate, wound site infection, only PL, RAPD, no glow. These are typically associated with streptococcus and GNB. So this is a patient who was operated elsewhere. 2 weeks from onset of surgery, she had presented with no view, hypopion, typical acute postoperative endophthalmitis picture. And she underwent vitrectomy. The organism was Corynebacterium, sensitive to Vanco, 2 VCD. She improved very well. And she followed up in Kolkata after this at 1 month. She had a supranasal break, atrophic break, which was lasered. And her BCVA is 6.6. And this is the picture taken at 2 weeks where she followed up in Kolkata. I don't have that break image. This is at 2 weeks. That time she was doing good. So this is again a patient who was operated elsewhere. So this I have put as acute chronic because the patient developed symptoms some 10 days from surgery. But then he was roaming with the diagnosis of inflammation and infection, injected, IV, so many things. So when he came back, it was already a month. And all again severe corneal edema, hypopion. These corneal changes were so difficult to operate. So when this untreated endophthalmitis, cornea I feel suffers the most. And it makes our life also miserable because intraoperative no view, it can be really difficult. And it was methicillin sensitive Staphylococcus xylosis, sensitive to Vanco again, 4 BCD, 6 weeks, BCVA was 6.9. So here I did really an incomplete job. I couldn't induce PO, I think I didn't induce PVD, and because like I mentioned of the corneal edema, and probably this is the condensed hyaloid with the epiretinal membrane. Luckily no break and no ERM on the macula, so I'm following him. So he's 6.9. So this case, it could be a repetition for a couple of people. Again, it's a typical acute postoperative endophthalmitis. She was culture negative, PCR U bacterium positive. We gave VCD. It's a debatable thing whether this is drug precipitate or exudates we had discussed in the class. And finally they disappear whatsoever it is. But her vision remained 6.18. Some corneal decompensation changes were there. Again, this patient also did well despite this little scary picture. And so this patient, this is our in-house case, and she was methicillin sensitive Staphylococcus xylosis. She presented POD4, and it was a severe form of endophthalmitis. And she didn't, even though sensitive to Vanco, Ciplox and imipenem, she didn't do well with Vanco. And the hypopion was not there postoperatively, but I couldn't see the media. So with 2 VCDs, we tend to see that she's improving, but it was not happening. Simultaneously, Dr. LG sir was treating one of the patients with the same staphylococcal species with imipenem. So if I were to choose between Ciplox and imipenem, then I saw sir's patient was doing well, so I switched directly to imipenem. But otherwise, given no experience with imipenem, I would have switched to Ciplox. But only problem, like I mentioned, it's daily injections. And this patient is super scared of injections. So she threatened me that if you're going to inject, I'm not going to come for follow-up. So then I chose imipenem. With 2 doses of imipenem, she did really well. And this is 2 weeks post-op. Again, I have left some vitreous and 6.9. Though imipenem is typically for GNB, sometimes it can work. Yeah, this is, I operated, I think, recently. He had some injury, then cataract surgery, AC wash. So this patient presented with no hypopion. But the thing is, he was documented as hypopion elsewhere, and he underwent AC wash. So this is why it is most important to go through the previous records. And it is better to scan it and put it in the computer also. And the one gross feature was very gross pseudophacodonosis. It stems due to remove the IOL in the OPD itself. It was that gross. And I so obviously wrote with IOL explantation. So there are viticos. Again, it is hemorrhage or what we don't know, but elsewhere it was documented as hypopion. It was written as endophthalmitis, so I had to err on endophthalmitis. So then on table we noted that was an iris claw lens. I'm not able to show here, but you can see that it is clipped here, and here also it is little bit eccentrically clipped. And iris claw unclipping actually can be very traumatic. So for the entire surgery it remained stable, and so I didn't touch the lens. Sometimes when we are dealing with IOL removal, we have to take the chance, we have to look, is the removal easier? So if it is grossly unstable, it moves, it tries to dislocate, it should be easier. But this is something which I didn't anticipate preoperatively. There were no proper records of the cataract surgery. So I was not knowing what kind of lens that was placed. I should have anticipated, I was anticipating glued IOL, but iris claw was something which I found on table. And this patient at POD 4, he improved to 624, IOL was stable, but again with pseudophacodonosis, but he did very well. Again, culture negative and PCR also negative. So chronic, so here our threshold for vitrectomy is very low because of the organisms mainly. But if it is P. acnes, sequestered organism, we can still give intracapsular injections. Of course, I don't have experience, but it needs multiple injections, and mostly it is reserved for patients who have very good visual acuity, and vitreous cavity is not involved much. And vitrectomy with IOL, plus minus IOL explantation followed by multiple injections again needs lot of counseling. And in fungal infection, we need prolonged systemic treatment, just like sir mentioned, because most are fungicidal. And systemic chronic inflammation, there is always, we have to remember that all chronic endophthalmitis is associated with chronic inflammation, which itself cause NVI, NVG, generally poor prognosis. Propionibacterium, cons, and fungi. So this is a 70 plus patient from Mauritius. So this patient was operated in Jan, and after that the patient's version is the patient's surgeon did not respond to him properly, and he was not seen post-operatively for 27 days is what the patient told me. And you can see that pigment in the entire eye, all you see is pigment. Actually there is a hypopion here with pigment. And so this is, I was wondering whether this is inflammation, infection, because he was treated again multiple places, different diagnosis. Then I showed to LG sir. Sir told this is chronic postoperative endophthalmitis and we'll proceed with IOL removal. And he is a patient who had diabetes with brain aneurysm, coiling and all that, some systemic issues also. And then we proceeded with vitrectomy. And so the most important point was this ultrasound, if you see, it's hardly not much viticose. So this is where it was confusing. This is preoperative. So this is why I thought this could be inflammatory. But then he was treated with the course of steroids at multiple places. He did not improve. So I was wondering whether this is that steroids not given properly, that full dose or something like that. But since sir suggested, I proceeded. Again, culture was negative, U bacteria positive. 4 doses of VCD we gave. Apart from that, he had angular closure glaucoma. So this is postoperative week 2. 6 weeks with plus 10D, he's 624. Now he wanted SFIOL. So we can see these sclerosed vessels, and I didn't have the courage to do SFIOL in this eye. So I think I sent to Chetan sir, and this patient had florid NVI, which actually I had missed. And the glaucoma people had seen, sir said, and both of them suggested not to go for any intervention. And he suggested him to be put on little longer time of topical steroids and reassess the inflammation and then take a call. But then I counseled the patient strongly against SFIOL. And again, with plus 10.5, he's reading 612. The other problem what this patient has is this corneal ulcer. So this is why, epidefect. This is why he is not keen for contact lens, and he was using contact lens in between at Mauritius. Then he developed this again. Post-operatively also he had while I sent him also, when he came back also he had. So I was wondering whether some recurrent corneal erosion, some kind of thing. So I was hesitant to put him on contact lens also. So this is the other problem we can have. And we did a UBM also. And so it was showing many features not to try any other procedure in this eye, like iris plaster, CB atrophy. So all these points, not a very favorable thing. And why I was showing this UBM is that all these are features of chronic inflammation. So we have to understand that endophthalmitis is an inflammatory condition as well. So sir, when he was presenting, it was very high, sir, something around 30. At this time, he was, I think, some 20 with one eye IgM, sir. So this is a patient. Again, it's a repeat for some people. So 6 weeks prior, she had a cataract surgery. And she presented with hypopyon, no view and all that. She underwent vitrectomy with IOL removal because the entire exudate was around the IOL. So this is what I meant when we see on table how is the condition. Actually, this patient did not have much exudates in the vitreous cavity. It was all around IOL. So I removed the IOL and it came out to be nocardia positive. I had injected amikacin with vancomycin because amikacin is the drug of choice for nocardia. And I landed up, so it was all nicely clearing. And thanks to Dr. Anand for sharing this photograph, we can see that this growth happens around IOL so beautifully. This is the bottle in which we have sent. So nocardia is very fond of these, foreign material. It forms biofilms, especially buccal and IOL. So I repeated just to make sure. I read lot of nocardia. I read it is known for recurrence, and I overtreated, landed up with this bigger problem. I repeated amikacin within 48 hours, and I did not want the patient to maintain sitting. So hard lesson. Patient developed a large macular infarct. So correct dilution, I injected the lower dose, but I did not make the patient to, I didn't want the patient to sit. After this, the patient did not have any recurrence of infection at this point of time, so I didn't inject, and I was observing her. POD 10, I sent her back, only to land up with this at 4 weeks. So we can see this nodule. So the most important, again, hard lesson is that nocardia has the tendency to sit typically under the inferior iris. It hides itself nicely and it comes back like this. So when we are doing the surgery also, we have to clear these recesses nicely. At that time I didn't know it is nocardia, but when we are dealing with any chronic inflammation, we have to check under all these areas. And one paper has beautifully described this thing. And when she came back, my guilt has gone, but now I have to control this. So I injected Ciplox, Vanco, amikacin, all these were sensitive. Absolutely no response. So then I didn't know what to do. So I sent to this ID specialist who have a lot of experience with dealing with systemic nocardiosis. Non-injectable antibiotic sensitivity, what we had was this oral Bactrim DS and Moxie. And she was treated for 1 long year, believe me. And with the 2 weeks from the onset of this, so she became like this. Then I understood that something is really working. But then the ID specialist strictly told me that it has to be continued for 1 year. I was like, for an exogenous infection. She developed so many side effects of Bactrim DS. Every time she shows her teeth, aise hua hai. So, but then I counseled her. 3 months, 6 months follow-up. We can see that these hemorrhages also have become, but vision remained counting fingers. So nocardia, this deep-seated infiltration one has to be aware of. And when we go through the literature, we see that nocardia was diagnosed after evisceration. Thanks to sir, we could get it from the vitreous sample. And with that next generation sequencing, we could find the species also, it's Nocardia puris. And it responds this deep-seated infection, they respond very poorly to any form of treatment. For an exogenous infection, also sometimes we need to have an internist opinion, and sometimes systemic medication can help, and we publish this as well. So bleb associated, like I mentioned, topical steroids we have to have caution. One strange thing is that this broache, almost all the papers on bleb BAE describes this is a most common prodromal symptom. So when patient comes with broache, some vague history for glaucoma, we have to be aware of this. Inferior location, leaking blebs, antifibrotic agents. When we take up this patient for surgery, we have to keep a patch graft, scleral patch graft ready, and we have to use fortified antibiotics with lower dose of steroids. The organisms are Streptococcus, Staphylococcus, Haemophilus. It is generally associated with a very, very poor prognosis. So this is the typical white on red. The entire eye is red with a white on top of it. So this is why you have to examine lifting the eyelid and everything. When some patients may not give any history also, they will say everything is cataract. So this is a patient who underwent surgery in 2002, and his last follow-up in 2018, 618 with 0.9. But then after the patient lost to follow from our institute, elsewhere he had only some hand movements are 1/60 due to glaucoma, and he presented with 1 week history roughly. We can see this is a very frank endophthalmitis, bleb associated. So the organism is, here I directly took the patient for vitrectomy, and the organism was Pseudomonas and some species, not Aeruginosa. And it was, the most important thing is it is resistant to ceftazidime. Both nocardia, Pseudomonas, our empirical antibiotic may not work. So as soon as we send the sample, it is our duty to check with the OT that the sample has reached the micro. And after the second, third postoperative day, we have to check the sensitivity. So even if the patient is doing better with VCD, we need to switch to a more sensitive antibiotic. This is to maintain the drug within the MIC with fewer injections and to reduce toxicity. And this patient, I had to inject Ciplox plus Dexa every day after the 2 doses of VCD. He responded better to Ciplox and with POD 10. Hand movements because of GOA, but infection is pretty well controlled. He's yet to follow up. And no bleb leak pre-operative on table at the final. His pressures are now controlled with AGM. And during surgery, the pressure was very high, so we had to give mannitol and take it up. When we are dealing with bleb-associated infection, we have to remember all these things. So less topical steroids, fortified antibiotics, look for bleb leak, keep the patch graft ready, IOP management, pre-surgery, post-surgery, then later. So later also this bleb is failed. So he will need some diode CPC or some form of IOP management.
Yeah, all this I generally, once it's healed, bleb is fibrous, so it's non-functional.
Yes.
So that's why IOP monitoring is extremely important.
Yes. So this is a second case. This is a different way of managing bleb-related endophthalmitis. So he came at somewhere in the night, so I don't have a slit lamp image. Phakic patient, most important phakic patient, hypopion, blebitis, and ultrasound hardly in echoes. So I called Chetan sir to ask what to do. He told you take AC-tap and inject. But absolutely no view of the fundus. I had a concern that whether I am taking the organism and going inside eye and all those things, but already there was vitreous. I couldn't see the fundal glow by which it's understood that there is some vitreous involvement also, even though we couldn't see in the ultrasound. And I think no growth in AC-tap or anything, alternate day VCD, patient really improved well. You can see this thin cystic bleb actually here. So this is healing blebitis. So 3 doses of VCD, patient improved very well. Last follow-up is 2 years. The patient underwent, he had multiple lattices. He underwent barrage laser, he underwent cataract, he underwent needling. So after all that, he is 6'9". Of course, little advanced glaucoma, but patient is doing well. There is a little strange looking ERM, but probably due to laser, inflammation and all these things. But it is not causing any metamorphopsia or actual traction, so I'm observing him. So early infection, like I mentioned, can be managed with tap and inject alone. And late infection, which is a severe form of infection, which I showed the earlier case, we managed with VIT. So this is again a repeat case. Post-ICL endophthalmitis presented with hypopion. Elsewhere, they have removed the IOL, and most important point, it's actually a big wound. It's not seen here. This much big wound, unsutured. So I am contemplating whether the organism entered during that procedure itself. They had a doubtful fungal isolated. They gave voriconazole elsewhere, but he worsened. So he came for further management. This hypopion and this fundus, definitely nobody will think of doing vitrectomy. We will try to manage like AC wash or AC tap injection. So it worsened. We did AC tap. It was panfungal negative. Like I mentioned, sometimes direct isolation or even PCR was eubacterium positive. So PCR shows false positivity with bacterial infection and false negativity with fungal infection. This is a case example for that. But then still fundus was okay. And I kept injecting VC, he worsened to hand movement. So at this stage, I did an AC wash. You can see that I have sutured this wound. From the AC wash, we picked aspergillus flavus. Then we started injecting oriconazole. He did not improve with intracameral oriconazole also. Finally, he became hand movements. So at presentation, it was 6 centing and it became hand movements. So now it was a clear lens to begin with. Just this picture, it became like this. And thanks to Dr. GSR. So I discussed with him and we proceeded with lens with IOAB. So he received 13 oriconazole injections total. And in between we had reduced topical systemic steroids. He developed hypotony. Then he hiked up. So plus 11, he is 7.5 using contact lens. Very keen for SFIOL, but I have told him to wait.
Did you try intracameral antifungals?
Yes, sir. So this, after this AC wash, no, sir. This is the picture after AC wash.
Okay.
So at this stage, I gave some 2-3 injections.
So this is a lens haze. This is not a, I thought corneal abscess, posterior corneal abscess.
No, sir.
I thought
This
posterior
is,
corneal abscess, the way it was looking.
No, sir. Cornea is clear. Actually, so I have the doubt that after AC wash, I nicely washed the fungus and I nicely seeded on the lens. That's the feeling I got.
This is not lens touch, obviously. So, but just the clue here is also when you have endophthalmitis and you see more or less fundus normal, always suspect fungus.
True, sir, true. But then I think he was, so even before AC wash also, he never responded to oriconazole, sir. Only after this vitrectomy he responded. I don't know why.
Probably in a section, suppose you at that time. That's why like a cornea, particularly avascular structure, probably would have started there where your antibiotic or your antifungals are not reaching. That can be the cause. But yes, and always these eyes need very, very prolonged treatment. Sometime even 3 months, 4 months, up to 6 months also, including systemic plus.
Yes, sir. Systemic. Actually, I missed that. He was put on oriconazole. So after AC wash, I was under the impression that it is not sensitive to oriconazole, but the sensitivity was, it was sensitive to oriconazole. So that was the other thing, little bit, this thing.
What was the dosage you gave for oriconazole, oral oriconazole?
Sir, 200 mg, sir, thought block, but BD and then, sir?
Was it a lens abscess?
Ma'am,
Lens abscess
this, yes. Initially, it was on table of AC wash, lens was clear, ma'am. But one feature is that some exudate was stuck here. But the problem was it was very close to the lens. I couldn't remove that. But then during vitrectomy, it was a lens abscess kind of.
Maybe that's why it was not sitting inside everything. So that's why you needed to remove it properly.
What was it all sensitive to? I mean, other than oriconazole? Was it sensitive to anything else?
I don't recollect.
Yeah, I know, but
I think intermediate to caspofungin, I think so.
Yeah. So sometimes oriconazole may not have the, what, as you said, rightly said, in vitro and in vivo don't match. In vitro they say that its MIC is good enough, but in vitro it doesn't work. Somehow it doesn't work. That dosage doesn't work, and there's a limit to what you can give. So you can switch agents very quickly also.
Yes,
with the
sir.
help of internist. If you think this is aspergillus flavus and it's not working with
Oriconazole, yes,
you
sir.
could have taken an internist's help and gave caspofungin also.
Also,
It would
yes,
have worked. May have worked.
Yes, sir.
One or the other drug may have worked because it is just seeding in the antechamber alone. It has not yet gone all around. Of course, there's always a counterpoint that even that wouldn't have worked and you had to ultimately do what you did.
No, sir. My only thing was, sir, at this stage, probably I should have tried, like you mentioned, some alternate.
No, but you had to take a sample, right?
No, sir. That's what I mean. Yeah, correct.
This was You took an AC tap or AC wash, which was saying?
Sir, I have taken one AC tap, one AC wash, then lens switch.
Which one showed the culture?
As AC wash.
So see, you didn't get anything in AC tap, so you had to do an AC wash. And then, of course, something has come. At least something came positive. If you had negative, you would have been struggling with
Yes.
whatever you're doing.
Yes.
So, that's why actually I would say class is very good today. Because see, this is afterthought and this excellent learning with this. Because this analyzing what exactly happened, that's what help us out. See, the decision was taken looking at a clinical situation at that time. So
Yes.
you cannot anticipate everything. So I think what was done in a systematic way, I think that's the correct way of doing it. But yes, this is also learning. Next time we can have other options keep in mind. That's the whole purpose, I think. I think that's the way I think that we can sit and discuss back and forth now. But I think what was done during that way, that's the first line of yes, and it is sensitive variconazole, it was there. But yes, it takes some time, long time to work on.
Yes. So post-traumatic, again, like I mentioned, variable organism depending on the scenario. So quick question, PG, the one who is chatting there. Yeah, you. Tell me what could be the risk factors for post-traumatic endophthalmitis. What are the features or history from history? You tell me what these are present, I will suspect endophthalmitis. No, it's like history of injury with vegetable matter, that way. So this history suggesting that there could be a foreign body, vegetable matter, only corneal wounds, lens capsule rupture. So all these are signs. And few studies have shown that a corneal wound which is unplugged by iris. So they say that if the wound is plugged with iris, it somehow prevents the entry of organisms again, but it can be inoculated on the iris surface. Two school of thoughts, but it has been shown definitely that only corneal wounds, anterocapsular rupture, needle injuries, they have high risk of endophthalmitis. Okay, that is the most important risk factor. And during surgery, wound management. So first we have to check. I have a case to show. Even if it's a self-sealed tear, before starting lensectomy, vitrectomy, we have to check for leak, and if needed, we have to suture. Of course, intraocular foreign body, I already mentioned. It's a very challenging scenario. We have two things to deal with the IFB. In endophthalmitis itself can cause media haze. Trauma itself can cause media haze, unstable chamber. So it is a difficult thing. We have to be more prepared. And the hazy media can be due to cornea or lens. Everything is hazy basically. And associated problems can be choroidal detachment, retinal detachment. This choroidal detachment we have to anticipate because there is an open wound. Definitely there will be choroidal detachment. And multiple surgeries, high risk of PR. There are two: endophthalmitis, trauma, both causes PVR on their own separately. When they are together, definitely it's going to be very high. Proper counseling, GVP. So, and poor prognosis, especially with bacillus. Like I mentioned, it eats the eye within 10 to 12 hours. So this is a patient, some 40-year-old male with injury with iron particle, 3 days, only 3 days. So obvious wound is not sealed. Actually, there is one self-sealed tear here. So hypopion, PL inconsistent, and full vitreous echos, and there is a foreign body. So I don't have a better image. And he underwent corneal tear repair, lensectomy, vitrectomy, IFB removal, and there were iatrogenic problems. Retina was detached. LPFC, RR, EL, SOI only, and I'll show the final picture. So it was bacillus. So after surgery, I recovered from the surgical trauma. Then I went to this microbiological trauma. Again, resistant to ceftazidime. So VCD, no response. Actually, at this point only, we got the sensitivity. So it wasn't actually post-operatively, as you can see. And this was the big corneal tear that I was telling you. And after Ciplox with DEXA, so little poor surgery, LPFC bubble in AC.
That's not LPFC, it's oil.
Yes, LPFC. And the exudates are reducing, cornea is clearing, infection part was taken care of. But I couldn't save the eye in the sense vision. He landed up with NPL. Actually, post-operatively only he became NPL, like in first 1 or 2 days. This is retina. This is retina. If you're wondering if there's a sclerosed vessel, that's how bacillus. I didn't do this, bacillus. So I did some RR like this, but then when he came for GI, I was like, where is the retina? So this is the destruction that bacillus causes. and we have to be really aggressive. 3 days from presentation is too long time, and it could easily. And on table also, it was a necrotic retina. To settle, to achieve, on table attachment was itself is very difficult, and laser won't take up. I have put the oil now, so from outside the eye looks okay. It's not pre-thesical, but vision is NPL, and that serious is the bacillus infection.
So what you saw post-operatively was actually debris which is there in the antechamber.
Yes.
There's nothing there inside the eye too, because you have put oil.
Oil, yes, sir.
So whatever is left over, the debris is coming, it's taking its own time to go. So it's
No,
just
sir. Actually, he from here he worsened with VCD.
His cornea is still clear and the wound is absolutely healthy.
Probably prone position. See, whatever left over debris just coming down and settling on the back of the cornea because it's oil filled eye. We are maintaining prone position. I mean, it's difficult to say. Fibrin will always be there because induced trauma, surgery induced inflammation and trauma is always there. Also added on, I think. But whatever destruction has already happened, what you are looking at it is because the 3 days, as you rightly mentioned, is already, I think, whole thing destroyed. But once you IN, you want to salvage, you want to just settle on the table. That's
It was an aggressive surgery. If I had seen retinal necrosis, probably I would not have done RR LPSC oil, nothing.
Yes,
Just
sir. I
IOP
learned
out.
that lesson, and
IOP out, vitrectomy done, close the eye. Wounds, that's it. Let it go into thysis.
yes, sir,
I
I
will
learned.
do it.
I learned that lesson little hardly. I have done that in a couple of cases next. Endogenous, a little poor prognosis because they usually present late. Because there is no inciting like surgery or trauma, it's not there. Patient will think anything, it will be like cataract only for them. So they come late unless they have severe redness, pain, and so forth. Sometimes the other way of presentation is patient admitted in ICU with so many multisystem infections. Again, it's very difficult to manage those kind of patients also. So blood and urine culture and investigations, like I mentioned, to look for the cause and effect. And intravenous antibiotics, mainstay of treatment, ID specialist. The same flow chart, but from beginning only we start broad spectrum IV antibiotics. So that is one thing everybody should remember. The most common denominator for endophthalmitis endogenous is diabetes. Typically they will have very, very high sugar. In diabetic patients, of course, fungus is most common, but many diabetic patients will have some soft tissue infections. Staphylococcal species and GNB is also very common. But overall endogenous endophthalmitis with Western literature, fungi is very common, followed by GNB, UTI. SST is skin and soft tissue infections. Staphylococcus is more common. This is our scenario. Like I told you, there could be some possible source like stent, catheter, and so on, which needs removal.
Klebsiella is very common.
Yes, ma'am.
Klebsiella.
So GNB. And during vitrectomy, we have to understand how the organism enters the eye, usually through a choroidal abscess. We have to be very careful in infusion because typically the subretinal abscess is located in ITQ. So we have to look for the abscess in the ultrasound when we are dealing with a case of endogenous endophthalmitis. So this is a 40-year-old female, and she had some ureteric calculus, and she had a DJ stent placement, and it was removed. And after removal, 1 week she had eye problem. It was hand movements in right eye, and she was already started with topical and systemic antifungals, and she was referred here. So this is the picture. This eye was hand movements, and this eye was 618. Actually, here the retinal details are seen, but clinically it was much, much hazier, and ultrasound showed significant vertigo. So I proceeded with vitrectomy in this eye, and so I wanted a sample basically, and the cultures which were done for the patient elsewhere were all negative. The urine culture, blood culture she had done there, so they were all negative. So it was candida basically, and so on table I injected voriconazole. Again, retrospective thought, probably I should have injected amphotericin because the clinical picture is more favor of candida. And urine culture grew Klebsiella, internist was involved, so he gave intravenous meropenem. So we were suspecting even polymicrobial infection. And she was, because candida, she was put on fluconazole. On day 5, again I repeated oriconazole. but then by that time I didn't have the sensitivity actually when I repeated. I repeated oriconazole in both eyes because the right eye was doing better with on-table oriconazole. So, and after that one injection, so one injection was on-table for the right eye and the next one was, I think, third day. After that, the right eye was clear, it did not receive any injections and it was stable, the infection did not recur. On the other hand, the left eye kept on worsening. I tried amphotericin, I tried oriconazole also, nothing worked. But like sir mentioned, it was sensitive to caspofungin, but some moderate sensitivity. To be honest, I didn't have experience with caspofungin, so I was a little hesitant. And you can see this right eye, it was clear. So this is how the left eye was, the exudate had increased. Then at day 9 it worsened, so I took it up for surgery. So post surgery for the first 5 days, absolutely no view. And it was really difficult challenge, and I showed both me and the patient needed moral support. So I went and discussed with Dr. LG sir. So he suggested to alternate caspofungin with amphotericin. And this patient was a very anxious patient, and sometimes it needs more composure than what we think. Especially she had 6/18. She went to hand movements. Post-operatively, now right eye has improved. She kept on asking, what did you do in right eye? Do that in the left eye. Why it is not improving? So it can be really challenging to handle the patient. So more to know how to manage, I sent the patient to sir to manage her first. So then sir spoke so well, and he gave me the idea of caspofungin also. This is after 1 day of injecting caspofungin. So retrospective thought, probably for the left eye, I should have injected caspofungin instead of amphotericin or oriconazole. But then it was showing moderate sensitivity again. So I alternated with caspofungin and amphotericin, 5 doses. And this is how she is at 1 month.
You got to give it systemic.
So she was on, actually sir, IV amphotericin was suggested by ID specialist. But patient was not willing due to toxicity.
No, but you could always tell the ID specialist that I want to give caspofungin, can you do it for me?
Okay.
You have to tell them, because you see the response to the...
Yes sir, but he suggested fluconazole because he says always candida respond to 2 main drugs is...
He may say whatever, you are seeing clinically.
Okay.
Clinically you know that what you're struggling with. And you say you got the only sample that comes positive, shows some sensitivity to something else. Why not try that? That's what I'm trying to say. You have to convince the specialist that I would like this. Can we give it a shot of
sir,
caspofungin?
in addition to caspofungin, after this you are saying, sir? Or before?
Before, when you got for the right eye, that
okay.
side.
Okay.
It would have cleared the left eye. Without,
okay.
Because Canada is very responsive to many medicines. If not this, that will work.
Okay.
Dr. Anand, even oriconazole is effective against Candida, right? This patient was resistant, right? But
sir,
usually it is sensitive, right?
Sir, even it worked for her right eye, sir, actually.
No, sir. The fungus behaves in a very different way. Sometimes they suddenly they become resistant to one drug, and then after some time they lose the resistance and again become sensitive. So it's a little difficult.
We have seen even organism may be resistant in lab, but because of your patient's immunity combined together, whatever he injected, even sometimes you have still good response.
And
the other problem with ampho is ampho itself throws up a lot of
inflammation.
actually.
Yes.
So finding whether it is responding or it's worsening or it
yes,
is
sir.
the reaction to the ampho is also difficult.
Yes, agreed. So this one patient, I had the opportunity to look for caspofungin toxicity because right eye is the control eye. And I did the ERG at 1 month because there are no studies on caspofungin toxicity in human eyes, actually. They have done only ERG they have studied only in histopath and rabbit eyes. So the responses were reduced, mainly some post-infective, post-operative sequelae, but comparable in both eyes. So we can say it is still a safe drug. And so this is another endogenous patient, endogenous endophthalmitis patient. she came, 54-year-old female, brought in stretcher with severe acute knee pain. Again, uncontrolled diabetes is the underlying factor. I couldn't image this patient, not even single photo I have taken, because this patient always came in stretcher. So, and she was systemically not very well. So this is a hypopion with corneal edema and thing, only 2 days history. 1 week back, she had a joint pain. She had all signs of inflammation on the joint. The joint is swollen, tender. So the moment you see, you know you're dealing with the septic arthritis. But someone elsewhere diagnosed it as osteoarthritis. Nevertheless, he has given physio also. And this patient presented with PL, total RD, underwent vitrectomy. So it was, retina was indistinguishable from vitreous exudate. It was white. No vessel, nothing could be seen other than the disc. And this patient had pre-retinal azotemia, and the anesthetist helped me to operate this patient. Like sir told, I deferred further RD surgery because the patient on table started developing slight breathlessness. So she was going into septicemia. We immediately shifted the patient to Mehta Hospital. She was there in ICU for 3 days. That arthroscopy, they drained the pus. The organism is group B streptococci, extremely virulent. It is very rare, but extremely virulent. It is seen in UTI, urinary tract of diabetic female patients. And it has affected the joint also. She couldn't walk, still she is in wheelchair. This is some 1.5 months from now. Full thickness retinal necrosis, total RD. She has hand movements vision. I put the oil, again on table decision to prevent phthisis. I even don't know what I thought. Because the patient was becoming sick, we directly shifted the patient directly to the ICU. So post-operatively, she received couple of injections, but she was started on 4 IV antibiotics, IV Vanco, IV meropenem, linezolid, tetracycline, IV. Tetracycline, I think they gave oral. After 10-15 days, she stayed in Mehta. She used to come once in 2 days. And then, So, last visit is 3 weeks from surgery. Vision was hand movements, oil-filled eye. Cornea was clearing, no exudates, but I deferred for the surgery. I examined the other eye also in every visit. The other eye did not luckily develop any infection. So the patient, when comes with some other complaint, like we can also look at the other source, like common is dental abscess, joint, more commoner is UTI. So we'll have to examine the patient as a whole. And before coming here, the patient was treated as seronegative arthritis with uveitis, and she received IV Dexa also. So I think we should remember the basic signs of common diseases, systemic diseases also. So keratitis associated endophthalmitis, same organism, sir. Same organism in the joint. No, so only in the joint. They didn't isolate in the blood. Same organism. And so before they could take the organism, because she was not systematically fit for whatever the joint procedure they could do, we gave the organism to the patient. So she was put on antibiotics based on our microbiology data. So that's how it is very important to get the sample in a case of endogenous endophthalmitis. And keratitis, ascites endophthalmitis is difficult. This is even more difficult. To diagnose, to treat, follow up, everything is difficult. Ultrasound plays a crucial role. It can be direct contiguous involvement from the corneal ulcer or a PK-related suture abscess or from a vitreous wick, just like a cataract surgery. Post-surgery vitiligo, very commonly seen post-TPK. It could be reactionary or hemorrhage. When we don't know what it is, we'll keep a close watch. And corneal, the main advantage is corneal scraping can give the organism. However, sensitivity is better with intraocular fluid. And lens is a very strong barrier. And intravitreal injection can be also challenging because there is thin cornea. In post-PK, the suture can give away. So all these factors we have to remember. And on table also, we won't be able to do much because it will be either temporary K-Pro or open sky. Only limited vitrectomy can be done. And better to be conservative because media will be very hazy and we'll need to close the case very quickly. So iatrogenic problems, very difficult to handle. The organism is Staphylococcus, GNB, and fungi. So this is a patient presented with a corneal ulcer. So initial presentation ultrasound was okay. The corneal scraping showed pythium. So pythium is a strange organism. Nobody knows whether it's a bacteria or fungi. It belongs to fungi but behaves bacterial, doesn't respond to any treatment basically very nicely. So post TPK with ECC, yeah, this is with the lens. I have not shown the lens echo, but you see how lens is an important barrier. And after that, she worsened. At this point, they started intravenous linezolid, fortified topical linezolid. Pythium is known to respond to linezolid actually, but she didn't do well. Again, they did re-TPK. At that time only there were vitreous echoes, but I think it was considered as reactionary. There was shallow detachment also. Yeah, post re-TPK we can see this exudate coming up nicely. Again, I showed this case to Chetan sir. So he told there is infection behind, that's why it keep coming anteriorly. And I took her for vitrectomy because graft is very clear. So entire fundus was normal and 360-degree parsplanal limbus were all plastered with exudates. And it was impossible to remove it completely. Debulking also was difficult. It was a very difficult case. Even there is view, even I can do much, I couldn't do much. So I induced PVD from the posterior pole. I trimmed at the equator. And she again worsened with total RD, NPL. Again, we kept on injecting intracameral linezolid. Again, NPL, failed graft. But patient pain went down, so she became pre-thesical basically. But pythium is one organism, it's called a swamp monster. So very radical surgery need to be done. And probably during the re-TPK, I feel the VR intervention could have been combined. But again, retrospective thought. So recently it is shown to respond to linezolid, azithromycin, minocycline and tigecycline. Pythium endophthalmitis is very, very uncommon, but it happens, it just destroys the eye. So coming to complications, corneal decompensation, retinal detachment, like I mentioned, these complications I kept on mentioning in the cases. Sometimes hypotonithiasis, all this can happen. And we also look for worsening. So this is a SIDA positive patient who came with query endophthalmitis, query viral retinitis. So this was the clinical picture, PL present. So we did, it was an endophthalmitis. It was not a peripheral viral retinitis. After surgery, vitrectomy, he was doing very well, pseudomonas, but then this happened. It's a GRT. And so at this time I had spared the lens because lens was clear. But then I had to take it up. So final visit 2 months, patient's vision is plus 13, 6.75, happily using contact lens. IOP is 10, oil-filled eye. He's yet to follow up. Again, sometimes even complications happen. I think with the right approach, we should be able to get away. So this I have put, let's just say a couple of cases, just to understand, as it is, it's a very difficult journey. Sometimes what we aim is infection control. We tell the patient when we manage, it is infection control, followed by eye salvage, followed by vision. So 40-year-old female, this patient I managed 10 days back, uncontrolled diabetes, history of some UTI, hypopion, full vitreous echoes, query RD, and she underwent vitrectomy. Her sugars were 300 and apparently her sugars were 500. It has come to 300 is what she says. So it was pneumococcus. First surgery, retina was okay, lens was clear, only core vit, but it didn't respond to vancomycin at all. So it was sensitive. She was given IV vanco plus meropenem by the internist, but didn't work. AC full of exudates. So I took it up for lensectomy and revitrectomy to find full thickness retinal necrosis and detachment. Retrospective thought whether I should have done lensectomy in the first surgery. Not sure. She responded only to intracameral linezolid and oral linezolid. So only injectable antibiotic to which she was responded was linezolid. You can see this necrosed retina here. This is a large break. So without exudates and the cornea is actually clearing, this is a better picture of her eye. And she's NPL. This is POW2. This is a post-traumatic case, pseudomonas, lens with IOB done. Even though retina is attached, you can see this axial. He received oral steroids, he received injections, his media cleared. All possible things were done only to land up with a pretheisical eye. Even though plus 24D, which is not practically feasible, he's 624. Again, this also can happen, even with the best management. So, sorry for the long class. So, it's an ocular emergency. Early vitrectomy is rewarding. And uptake microbiological diagnosis is important. Multiple injections. So, guarded vision need to be counseled. Purpose of surgery has to be properly explained to the patient. Documentation is important. Prevention is the ultimate goal for surgical, endogenous, blood-related trauma. Probably the most important slide. So every case I must have mentioned one of my senior colleague. They all have taught me. And special thanks to Dr. Anand sir, he was the person who will call wherever you are in the hospital, even in your vacation, he will call and tell you what is the organism he has isolated. Thank you so much, sir. And when patient is not responding also, you can go back to him and check to look for specific sensitivity. And thank you so much, sir. And all my fellow senior residents who have helped in ultrasound, to inject, and the anesthesia department in selected cases where they have helped me to shift the patient immediately when the patient was sick, and the MOT team. Thank you so much.